In a kickback statute, safe harbors, they describe various payment and business practices that, although they potentially implicate the federal anti-kickback statute, are not treated as offenses under the statute, again, provided the agreement is written up and is operated in conformance with that arrangement that, again, fits into a safe harbor. Here's a site to the safe harbors. There are many, and they cross different aspects of medical practice, including group practice, ancillary services, internal referrals, et cetera. One that we want to focus on for Academy members that also shares elements with the Stark exception that will be discussed in a moment is the personal services safe harbor. And again, the general elements are that your services, if you're rendering services to another entity, and this is where we see the development of medical director agreements with home health agencies across Academy members and others in the field, that the agreement be in writing, that all services to be rendered in the arrangement or to be provided or set out in the agreement. The agreement is for at least 1 year. Generally speaking, there's not an opportunity to modify the agreement in terms of payment situations within the year, and that is that the federal government, Congress, CMS, the OIG, did not want to see situations where volume could be reflected or addressed by changing the payment terms within the year of the first year of the agreement, or within a year at a time. That aggregate compensation paid over the term of the agreement, as mentioned, is set out in advance. It's consistent with fair market value. You often see that just in the acronym FMV, in arm's length transactions, and it's not determined in a manner that takes into account the volume or value of referrals that are generated between the parties for which a claim can be submitted, so that those professional services, in the absence of the ability to for a patient to go the other direction, that the value of those professional services would be the same. And services performed under the agreement do not involve the counseling or promotion of a business arrangement or other activity that violates any state or federal law. And again, these are elements that you often see as the basis of medical director agreements, and those are included in the medical director materials and booklets of the Academy that are available on the site. And also in that booklet are sample agreements and terms of services. In terms of determining fair market value, was often recommended, again, through services of consultants, accountants, is to establish surveys in your local market for whatever services that are under consideration in that personal services agreement, so that you have some survey information and are fitting within the range of payment for those services. In a kickback area, it is the Office of Inspector General. If you want to know in advance whether a prospective relationship or agreement would comport or run afoul of the anti-kickback statute, you can submit a request for an advisory opinion setting out the facts and circumstances of the arrangement. Those are not only returned to the requester, but they are also posted on the OIG site, so you can see others that may be applicable to the arrangement that you may have under consideration. And the purpose is to provide meaningful advice on the application of the anti-kickback statute and other statutes in specific factual situations. The advisory opinions are binding and then can be relied upon you if you are the requester. But again, it has to do with the facts and circumstances in the specific statements, and so no third parties get the effect of that advisory opinion or could rely upon them. It's only the specific requester. But again, they are helpful to see and to get a sense of what the OIG opines that would implicate the anti-kickback statute, and then also those arrangements that it feels do not produce a likelihood of risk to the program in terms of fraud and abuse, or that do fit it within a safe harbor. Moving on to the Stark Law. The physician self-referral law, again, or Stark Law, known for the congressman who first was the major proponent, prohibits a physician from making referrals for certain designated health services payable by Medicare to an entity which he or she or an immediate family member has a financial relationship, and that is can be through ownership, investment, or compensation, unless an exception applies. Again, there are many quantitative exceptions based on scale and the market and the ownership relationships. We're not going to go into detail of all those this afternoon, but just want to let you know that they are out there and whether others could participate in those situations. And also do know that the Stark Law applies to physicians. It does not apply to nurse practitioners or PAs, but in practices where we are in team practice, or there are different licensed professionals within the practice, we want to be aware of the Stark Law. And it also prohibits the entity from presenting or causing to be presented a claim to Medicare for those referred services. And again, as mentioned, there's exceptions, and it grants the Secretary of Health and Human Services the authority to create regulatory exceptions for financial relationships do not pose a risk of program or patient abuse. To break out that referral language a little bit clearer from the prior slide, again, the Stark Law prohibits a physician from making a referral for certain designated health services to an entity in which the physician or immediate member of his or her family has an ownership investment interest, and that is so that there just isn't a way of covering up the financial influence by having the ownership in through one's spouse or children, etc. And again, unless an exception applies, note that the Stark is a strict liability statute. Anti-kickback statute, which we discussed earlier, is a knowledge-based, intent-based. Stark, if you violate the terms, you violate the terms. What are those designated health services? And you'll recognize that services which you order or are involved in or are needed by your patients in the home are included in this list. When it's there for you to see here. Just to highlight, we do know that DME, for example, prosthetics, home health services are included, and the therapies are included on the list, as well as lab services. If you want to drill down and see if a specific code of a service there or test that you may order is included. For certain of the designated services, we'll see in the next slide, CMS actually maintains a list by code on the CMS site of the designated health services. And they update this year annually, and also do that in conjunction with the fee schedule final rule, and that'll be coming out in November of this year. Here are those services and the slide differentiates between those where CMS does maintain a code list and those for which it does not. currently maintain a code list. Similar to the anti-kickback statute, STARC has an opportunity, the anti-referral law has an opportunity to seek an opinion, advisory opinion, whether something would comport with the law or possibly be implicated or run afoul of the STARC provisions, and subject to either the practice or arrangement to penalties. And instead of going to the OIG, the STARC law requests go to CMS. Without going into the detail, here's just a broad outline of what they request in the application procedure, and this opportunity is on the CMS site, and again, we'll provide links to that in the posted materials. So in each situation, you have the opportunity in advance. That's the important point here, is you have the opportunity in advance to describe the situation as it's being planned or considered, and get that opinion upon which you can rely. Again, the elements of personal services exception are very similar in STARC as they are in anti-kickback, and I've just basically have replicated the slide here and as reviewed earlier. And again, for safety, again, you can always look into the personal services agreement opportunity to provide services so that with these requirements and criteria being met, so that you know that the arrangement again comports with federal law and state law likely as well. With the development of accountable care organizations, fraud and abuse provisions would attach. So those systems and advocates for accountable care organizations requested that Congress and CMS set out some waivers or exceptions that would enable accountable care organizations to provide the services in a cost-effective and reasonable and logical way that makes sense from a care perspective, also organizing, integrating care, and also from a financial savings perspective that makes sense and meets the intent of the shared savings programs and accountable care organizations, and that organizations wanted to have that protection set out in advance so that they could develop their applications and establish and grow their organizations. Why it's important for Academy members to know about this: again, house call practices provide documented value to accountable care organizations. We're seeing that in the Pioneer ACO results that are being published. ACOs require the services of house call practices to impact care and savings for the sickest and costliest patients. House call practices, again, from an advocacy perspective and representing yourself, we would encourage you to seek compensation based on the outcomes contribution to ACO quality and shared savings that you produce by taking care of the sickest and costliest patients and avoiding admissions, et cetera, and creating savings and patient satisfaction and quality meeting of quality measures on behalf of the ACO, versus just accepting a general primary care provider fee schedule amount. So again, to try to make things a little bit more commensurate. And the waivers are implicated and useful in this regard. There are 5 waivers. If the organization fits within one, the ACO can proceed. Again, this may be, you may be involved in ACO development, you may be in discussions with some, but again, wanted you to be aware of this existence and again, the value that you're providing. So these are the 5 waivers that are set out for accountable care organizations. Do know that again, states have mini fraud and abuse, or again, what's called mini fraud, their own fraud and abuse, and also their own referral, anti-referral, or by the influence of economics laws and regulations, and that you want to scrutinize what you have or what you're considering both on the federal level as well as the state, and that the states are encouraged now through federal regulation to really beef up and tune up their false claims statutes. And they're incented to do so by federal regulation now. Okay, Part B, coverage of house calls, we covered earlier this summer. Just want to reiterate that is, again, part of your documentation and claims comporting with medical necessity requirements and why you're there in the home in lieu of the patient seeking or being able to receive services in the office setting. And this is the general requirements that's in the compendium, well, that's in the Medicare coverage manuals, but is also included in the compendium and will also be included in or here in the slides from this afternoon. Moving forward, want to make sure that you establish that primary care provider relationship for your current services, again, for compliance reasons with claims and documentation and payment from a fee-for-service basis, but also in terms of the evolving services that are coming about, such as care management services, where there may be both face-to-face services and non-face-to-face services by yourself and your staff, and that the beneficiary is going to need to know about that, so you want that relationship documented. And the final rule will set out the requirements for that beneficiary consent for those services for 2015. And again, some things that you want to start to plan now for in terms of your medical record documentation, your relationship with your practices, and clinical and operational throughput. And you see that planning here. Who are those beneficiaries who are likely to benefit from your care management services? Consider that there may be kickouts or inability to bill for what's considered duplicative services, such as care plan oversight, et cetera. So you need to see whether a patient has home health services going on or not. Work on your continuity care records and ability to communicate that. Again, this is also going to be important from patient attribution and accountable care organizations, also in your private health plan relationships and shared savings relationships. Okay, compliance plans are mandatory. To leave some time for questions. We've touched on this again earlier this summer. Compliance plans, as a result of the ACA, are as the Secretary sets out regulations and specifications, are mandatory. Fortunately, what CMS has now done, beyond the general outline of what is there for a practice's compliance plan, they now have specific checklist posted on the CMS site, and I'm not going to go over all the specific points or items of the checklist, but just to let you know that they're here, again, part of the slides, and we'll provide the links to these on the CMS site. Here's the overarching elements of a compliance plan. That's available on the OIG site and as well as CMS site that we've discussed previously. And then in terms of more detail, under each section, here are the checklists. So you can use this checklist or outline for your own compliance plan development. And so this is a welcome resource for practices of all sides, particularly those Academy members. So these are the written policies and procedures and standards of conduct, compliance plan program oversight, and the officers, officials, committee responsibilities and authorities. Training and education elements, opening the lines of communication, and the ability, again, as I mentioned earlier, for questions to come in by paper or electronically, and anonymous drop boxes from patients, yourself, phone numbers, etc. Auditing and monitoring systems in place, and risk assessment, what codes you want to evaluate for your practice that you find are problematic areas or those set out by in the OIG work plan. Risk assessment, you see at the bottom, as mentioned, the areas of concern, and that you include them in your self-identified plans and that are updated and on an ongoing basis. More information under the auditing and monitoring section, and then response to detected offenses, disciplinary procedures or practices, corrective actions. So that completes the section of the webinar on the checklist that CMS has developed and now posted, and will provide the links to. Upcoming Academy webinars that will be helpful regarding your contractual relationships, and we'll pick up more on the information introduced this afternoon. Will be later in October. Then scheduled for November 13th, but we may push back after the final rule is published so that we have the specific language to build around and reference plan of care, chronic care management or care management services, and measure reporting for 2015 and going forward for your practice and payment and organization. And then do want you to begin making plans now, put on your calendar, and look forward to a great next annual meeting, May 13th and 14th of next year at Gaylord National Harbor Hotel. So this will be a return from 2011, National Harbor, Maryland, near Washington, D.C. Included there will be practice management sessions that will include information that's been discussed on this webinar, and then also important clinical and policy updates for you to take back to your practices. Again, the home care medicine compendium is available, and an opportunity for a discounted opportunity within a couple weeks from this today. That should be read September 11th for the promotion. And again, be glad to address questions that we can by phone now, or to research them. The Academy, we effort, as you know, to help you out as much in your local practice situation, but due to just capacity and then resource constraints, and also for liability reasons, there's so far that we can go in terms of our technical assistance. And so what you always need to do is to have the T's crossed and the I's dotted, and things scrutinized by local consultants and counsel. And again, the major point of this afternoon was to make sure that you're aware of these aspects to practice, the increasing complexity and the regulatory overlay, and to give you the opportunity to interact with those that you're developing relationships, or and also within your own practice, in compliance activities, and also to be able to effectively interact with those that you may be developing relationships for and with in terms of acquisitions or services to be rendered, et cetera, and also again for that professional and cost efficiency and with those experts and advisors that you seek out there on the local level. So any questions we'll try to address. You can also please feel free to email them those questions to me that come to mind at gary.swartz@aahcm.org. I'll give things another moment, but do hope that that your local situation there and environment and patient care permits you to enjoy a holiday weekend. Thank you for joining us this afternoon. Keep in touch, and we'll speak again by webinar in October. Thank you.